Hi, good morning. I want to thank Dr. Clark and Audrey for inviting me to speak to all of you today. So, today I'm going to talk about some of the work that we've been doing in the past few years to understand the genetic underpinnings of neuropsychiatric phenotypes and a bit about the molecular mechanisms that lead to those phenotypes. So I'm going to start with a case study. This is a 7-year-old right-handed little girl who I first saw a number of years ago, who came to me with a diagnosis of attention deficit hyperactivity disorder, but really pretty severe ADHD and somewhat atypical in that she had other behavioral issues, including aggressive behavior towards her mother and towards other children. She was also somewhat atypical in that she failed stimulant medication, the standard therapy for ADHD, due to worsening of her symptoms. She was started on lamotrigine, mostly for mood stabilization, with some initial improvement in neuropsychiatric phenotypes, including her hyperactivity and aggression. However, after a couple of years, these phenotypes reemerged and now were associated with even stronger behavioral outbursts, such as screaming and again hitting uh, other individuals, including family members. So I'll come back to this girl in a few minutes, but what was interesting was that by genetic testing, we found that she carries a duplication of chromosome 22q13 that involves a gene called Shank3. And I'll go into quite a bit of detail about Shank3 in the next few slides. So, as all of you, I think, are probably well aware, the synapse is the point of communication between neurons, and synapses are found most prominently on structures called dendritic spines. If you look at the image on the right, you can see a mouse neuron counterstained in green with Shank3 labeled in red. So these represent active synapses in this mouse neuron. You can see there are just thousands of these points of communication or synapses in a typical neuron. Diving a little bit more into Shank3's molecular function, Shank3 is found in the postsynaptic space. And there it serves as a scaffolding protein linking the overlying transmembrane neurotransmitter receptors to the underlying cytoskeleton and primarily F actin elements, which helps to provide physical structure to the postsynaptic space. So, a number of years ago now, we were interested in understanding what happens when we overexpress this gene Shank3. The reason we were interested in this is that it was well known that haploinsufficiency of Shank3 in a disorder called Phelan-McDermid syndrome results in severe intellectual disability, autism, and in cases epilepsy. But little was known about what happens when there's too much Shank3. So this really started as a basic science question. And we used mouse genetics, a technique called back transgenesis, to overexpress Shank3 in mice to determine what happens both at a behavioral and a molecular level in terms of phenotypes. We created these mice and found that there was, in fact, overexpression of Shank3 by about 50% compared to wild type animals. So in the next few slides, I'll go through some of the phenotypes that we found in these mice relatively quickly to get to some new data that we have. So these mice, we underwent a battery of behavioral tests, and I'll really just focus in detail on one and kind of gloss through some of the other phenotypes that we saw. We measured activity in these mice, and we did this in a novel environment using an assay called open field assay. Basically, we place mice in a plexiglass chamber and measure their activity in three-dimensional space. And so when we did this for our Shank3 overexpressing mice, what we found was that the Shank3 overexpressing mice are significantly hyperactive compared to their wild-type littermates. And this is true both for male and female mice. In fact, these mice were so hyperactive that we thought that these might be a model of ADHD and decided to treat them as you would treat a patient with ADHD by giving them a low dose of a stimulant medication to see if we could reverse this phenotype. Interestingly, when we did this, we found exactly the opposite of what we expected. So here again is data shown from an open field assay. The first 30 minutes of the graph on the left shows the baseline hyperactivity of mice, of Shank3 overexpressing mice. And then 30 minutes into this test, we gave half of our mice, half of the SHANK3 overexpressing mice, and half of the wild type mice, a low dose of amphetamine. We found for wild type mice there was a slight increase in activity as we expected. But for the SHANK3 overexpressing mice, we found exactly the opposite of what we expected, which was a dramatic increase in their activity. And that's shown quantitatively over on the right. We performed, as I mentioned earlier, really a battery of behavioral tests, and I won't go through all of them. But just to say that in addition to hyperactivity and increased sensitivity to amphetamine, we found changes in sensory gating through acoustic startle response and pre-pulse inhibition. We found a decrease in immobility by tail suspension testing, which is thought to indicate decreased despair in these mice. We also found abnormalities in socialization. And then on the neurophysiologic and molecular side, we found abnormalities, hyperexcitability of neurons in the SHANK3 overexpressing mice, as well as spontaneous seizures. But really, it was putting together all of the behavioral abnormalities that we saw in these mice that we thought that they actually may model a manic-like state. And so we wanted to determine whether treatments that are used for manic states in humans could rescue some of the behavioral phenotypes that we saw in these mice. And so we began by looking at lithium, and I'll go through this data again very quickly. We chronically treated mice with lithium and measured all the behavioral abnormalities that we saw in these mice. And basically, we found no significant rescue of any of the phenotypes, and shown here is the activity data. We found no significant rescue with chronic treatment with lithium. So we scratched our heads a bit and decided to try a different drug that is used for many in patients, which is valproate. Of course, as neurologists, we all use this primarily as an anticonvulsant, but it's also approved for manic episodes and bipolar disorder. It has a variety of molecular mechanisms. We used a subacute paradigm where we treated mice 3 times over 2 days with valproate and then looked at multiple behaviors following treatment. And basically what we found is that valproate could really rescue most or nearly all of the behavioral abnormalities that we had found in these mice. And again, I'm just showing the activity data here, where we found that treating SHANK3 overexpressing mice with valproate could rescue the baseline hyperactivity of these mice, as well as the accentuated hyperactivity induced by amphetamine. So, in addition to that, at the same time for this first report, we also looked for patients with duplications in SHANK3. There were a number of reports in the literature of large duplications involving many genes that were associated with neuropsychiatric phenotypes, but we really wanted to hone in on SHANK3. We found 2 individuals with the smallest duplications of chromosome 22q13 that had ever been described. In fact, these duplications involved primarily just SHANK3. One of those patients shown here was an 11-year-old girl, different from the one I discussed previously, who had a diagnosis of ADHD, but also atypical in that she poorly responded to stimulant medications. And she was subsequently diagnosed with bipolar disorder. She also had other behavioral issues, such as obsessive behaviors and food-seeking behaviors, and a history of epilepsy. The second patient we identified was a 35-year-old man who had been diagnosed with bipolar disorder as a teenager. He had a long psychiatric history with multiple hospitalizations and multiple medications used, as well as multiple suicide attempts and epilepsy as a teenager. So it was really the combination of our mouse studies, as well as identifying these 2 patients with neuropsychiatric phenotypes, that we believe we could confidently say that overexpression of SHANK3 causes neuropsychiatric disorders. But next, we wanted to hone in on which neurons within the brain are responsible for the individual phenotypes that we saw in both our mice as well as in patients. And we decided to look specifically at the striatum for a number of reasons. First of all, SHANK3 is most highly expressed within the striatum. So there are 3 SHANK genes, SHANK1, 2, and 3, with SHANK3 highly expressed in the striatum and expressed at lower levels in other regions of the brain. In contrast, Shank 1 and 2 have sort of a reciprocal expression pattern where they are more highly expressed in regions such as the cortex and the hippocampus compared to Shank 3. The other two reasons that we were interested in looking in the striatum is that the striatum is well known to be a center for dopamine signaling. For example, in the image at the lower left there, you can see that the D2 dopamine receptor is highly expressed within the striatum. And medications, drugs that are used for treating mania, some of those drugs are D2 dopamine receptor antagonists. And I'll come more to that more in a few minutes. The final reason we were interested in looking at the striatum is based on amphetamines' mechanism of action. So amphetamine is known to increase dopamine content within the synaptic cleft, and it does so through a variety of mechanisms, including inhibiting reuptake of dopamine, as well as promoting efflux of dopamine out of the presynaptic space. So to begin to address this, we performed neurophysiology. This was in collaboration with a neurophysiologist at the NRI, Wei Wang. We looked at synaptic neurotransmission in our Shank3 overexpressing mice. We did so first just in all medium spiny neurons within the striatum, and what we found was that there was increased synaptic neurotransmission in our Shank3 overexpressing mice as measured by miniature excitatory postsynaptic currents, or miniature EPSCs. What we found was that there is an increase in frequency of miniature EPSCs, but a normal amplitude of the miniature EPSCs. And this typically indicates an increased number of functional synapses. But what this did not address is really what is the cell type within the striatum that is dysfunctional. The striatum is composed primarily of two different types of medium spiny neurons, those that express the D1 dopamine receptor and those that express the D2 dopamine receptor. So we looked at these specific types of neurons within the striatum and again performed neurophysiology. What we found was that for D2 neurons, there was the same increase in frequency of miniature EPSCs that we had previously seen in the bulk measurements, but there was no significant change in D1 neurons. And again, we found that the amplitude of both D2 and D1 neurons of miniature EPSCs was normal. So again, suggesting dysfunction specifically of D2 neurons within the Shank3 overexpressing mice. So next, we wanted to determine whether we could use pharmacologic means to further assess the dysfunction, and in particular, whether we could rescue behaviors targeting D2 neurons. We initially started with a clinically approved D2 antagonist called clozapine. When we administered clozapine to our Shank3 overexpressing mice and their wild-type littermates, we really got a significant side effect with all of the doses that we administered, which is they all developed catalepsy and basically just sat in the middle of the cage. And this sort of side effect is something that's known for clinically available D2 antagonists because of the mechanism of action of clozapine and other clinically available D2 antagonists, which is while they do inhibit the D2 receptor, they do so by inhibiting both of the major canonical downstream signaling pathways of that receptor, which is inhibition of the beta-arrestin pathway as well as inhibition of the G protein pathway. Recent literature has suggested that inhibition of the beta-arrestin pathway downstream of the D2 receptor is responsible for its antipsychotic properties, whereas inhibition of G proteins is responsible for some of the side effects that we see with clinically available D2 receptors. So we turned to the Broad Institute, which was developing novel D2 antagonists that were biased towards inhibition of the beta-arrestin pathway without inhibiting the G protein pathway. And we were able to obtain two compounds that they had developed, BRD4018 and BRD5814, that again specifically inhibit or bias towards inhibition of the beta-arrestin pathway when they inhibit the D2 receptor. We again performed in our Shank3 overexpressing mice a subacute paradigm where we injected these mice 3 times over a couple of days with either BRD4018, BRD5814, or vehicle, and then measured behavior 30 minutes or 1 hour after administering this compound. And I won't show you all the data, but I'll show you the activity data that we found, which is that we could very potently rescue the hyperactivity that we saw in these mice, both with BRD 4018 and at least partially with BRD 5814. That's shown in panels C and G. We also found that these compounds could rescue the accentuated amphetamine-induced hyperactivity that we saw in the Shank3 overexpressing mice, and that's shown in panels D and H. We looked at another behavior that you can measure by open field assay, which is rearing activity, and found that these compounds could also rescue the abnormalities that we see in rearing activity in these mice. So next, we wanted to ask whether we could use a genetic paradigm to specifically rescue Shank3 overexpression in D2 neurons and rescue phenotypes associated with Shank3 overexpression. To do this, we used some standard mouse genetics, which is Cree-LoxP system. You've heard a bit about that before. I won't go through all of the quality control data that we did, but our experiment was to, again, rescue normalized expression of Shank3 in D2 neurons only, such that Shank3 dosage was normal in these neurons, but overexpressed elsewhere within the mouse brain. And what we found when we did this is that we could specifically rescue the accentuated response to amphetamine in these mice back to wild type levels. So next we wanted to try to understand at a molecular level why overexpression of Shank3 in D2 neurons results in these phenotypes. And so to do this, we wanted to identify all of the proteins that interact with Shank3 specifically within the striatum. We did this using a biochemical technique called immunoprecipitation. This was followed by mass spectrometry to identify those Shank3 binding partners. And when we did this, we found the Shank3 interactome within the striatum, which is shown in green here. We then performed bioinformatic analysis to ask whether there was a closer interaction between the Shank3 interactome and the D2 dopamine receptor versus the D1 dopamine receptor. The D2 dopamine receptor interactome is shown in red in the graph on the left, and the D1 dopamine receptor interactome is shown in blue. And I think you can easily see that there seems to be a more intimate connection between the Shank3 interactome and the D2 interactome versus the D1 interactome. That's shown quantitatively on the right, where we looked at the shortest path between any given member of the Shank3 interactome and the D2 receptor versus the D1 receptor. What you can see in that graph is that the path length from a member of the Shank3 interactome to the D2 receptor is significantly less than that of either all of the background proteins together or the D1 dopamine receptor. So turning back to our patient, again, she was initially, when I first saw her, a 7-year-old little girl with ADHD, but with atypical ADHD. She was actually retried on stimulant medications again at a later point in her life by another provider, and she again had worsening of her aggression. So this was very quickly stopped. I started her on risperidone, a clinically approved D2 dopamine receptor inhibitor, with resulting significant improvement in her aggression, her hyperactivity, and even in her ability to concentrate at school. So I'm going to shift gears just a little bit and talk about some work that was really inspired by our work on Shank3, the Shank3 overexpression study. So we were interested in trying to determine whether we could identify other variants in genes that predispose to neuropsychiatric phenotypes. And our approach was to try to identify those individuals with really early onset severe neuropsychiatric phenotypes, and then investigate those through genetic studies to try to identify new variants, new genes and new variants that could predispose to neuropsychiatric illness. So to do this, we've been obtaining DNA both from these early onset severe neuropsychiatric patients as well as their family members. And either they're unaffected family members if the proband is the only one in the family with a neuropsychiatric illness, or both those affected and unaffected if there's a strong family history of neuropsychiatric illness. We perform both genomic structural studies through array-CGH, looking for copy number variants, as well as whole exome sequencing, looking for single nucleotide variants. And then we determine bioinformatically whether or what de novo or inherited variants segregate with neuropsychiatric disorder in a given family. So far, we've collected DNA from nearly 100 probands with a variety of neuropsychiatric diagnoses, primarily with bipolar disorder and obsessive compulsive disorder, and begun to perform sequencing and array CGH on these patients. And I just want to highlight a very recent success using this approach. So a patient was referred to me, a 9-year-old little right-handed boy, for significant behavioral outbursts, inattention, impulsivity, and anxiety. Although there were some early developmental delays, specifically in language development as well as in gross motor development, his full-scale IQ is actually 97 at 7 years of age. Despite this, he was approximately 2 years behind his peers in school performance, and both his parents and his teachers felt this was primarily due to behavioral dysregulation and non-inability to perform the material. He carried a number of neuropsychiatric diagnoses. These included ADHD, obsessive compulsive disorder, as well as dysregulated mood disorder. He was also noted to be a restless sleeper, had no significant history of seizures, and no significant family history. Despite not having a significant history of seizures, an EEG was performed during his workup, and he was found to have generalized epileptiform discharges without clinical correlate. So when he saw me, we performed a variety of genetic testing. We performed array CGH, which revealed no significant copy number variants. But what we did find through exome sequencing was a de novo mosaic variant in a gene called TUB2A. This gene encodes a subunit of tubulin, which is very highly expressed within the central nervous system. The particular variant that we identified changes a glutamine to a proline at a very conserved residue. But again, it was only found in 120 out of over 360 reads in next generation sequencing, indicating this is in fact a mosaic event. This particular variant has been described before, at least in a germline variant in a patient with a significant developmental delay, cortical dysplasia, and intractable epilepsy. But our patient was found to have a normal MRI. Just a bit more about TUB2A. So again, germline mutations have been identified in neurodevelopment in patients with neurodevelopmental disorders. Many of these have abnormalities that are found by neuroimaging. These can include cortical dysplasias as well as abnormalities in the corpus callosum. The vast majority of patients with pathogenic variants in this gene develop seizures, and these are often refractory. And these patients also have very severe developmental delay, really global developmental delay, but probably most severe in language development, with many of these kids being nonverbal or only speaking in single words. Most of these kids also have behavioral abnormalities. They're impulsive, they're hyperactive. Many of them are diagnosed with autism. But you can see this is somewhat in contrast to our patient with the mosaic variant, which had a relatively milder phenotype, at least in terms of his development and his cognitive ability, but had some of the similar neuropsychiatric phenotypes as have been seen previously. So this patient was started on lamotrigine, not so much for the epileptiform discharges, but really more for behavior modification. And there was, in fact, significant improvement in his impulsivity and disruptive behavior with lamotrigine. So I'm going to end there and just mention some people that have really helped tremendously with this work, and really highlight Maria McCormack, who's my research coordinator, who's been intimately involved in recruiting patients for our initiative to identify neuropsychiatric genes. And if anyone in the audience perhaps has a patient like this who they've always thought perhaps could have a genetic issue, but typically insurance companies won't pay for this, feel free to contact me to discuss it, or contact Maria, and we'd be happy to talk to you about potentially enrolling them in our study. So I'll end there, and thank everyone for their attention.
Dr. Holder, again, what a tour de force. I remember seeing your Dodge Young Investigator Award speech, and just it really changed how I think about uh, the immediate benefit of genetic testing for kids with neurodevelopmental disorders and how it can really change management. So we have our first question from the audience is the theme of the morning, which is cerebellar function. And one
Mm.
person is asking whether Shank3 is involved in cerebellar function and if that could contribute to phenotypes.
Yeah, that's a really terrific question. So Shank3 is expressed in the cerebellum. So I didn't go through all of these details, but Shank3 has three major isoforms from the same gene, and only one of those isoforms is expressed within the cerebellum. I've not really seen any work that has been done specifically looking at Shank3's function in the cerebellum. I've always thought about it, really, probably, well, I shouldn't say always, probably after I heard Peter Tsai's talk about tuberous sclerosis, thought about it. And I've always assumed somebody would look at that. Nothing's ever been published. So it's really an unknown. Maybe Peter will do.
Yeah, sounds like a great collaborative opportunity. Another question is sort of practical in terms of clinical care. So first of all, are there clinical tests like the pharmacogenomic testing that's becoming sort of more mainstream? Would that help in the evaluation of patients with neuropsychiatric disorders? And somebody had a very practical question about where would we put that information in a chart so that other healthcare providers could see it?
Yeah, that's a great question. So there is pharmacogenetic testing that can be done. Usually it's not covered by insurance, or I think only sometimes covered by insurance. Most of that pharmacogenetic testing is looking at metabolism of medications that we use for neuropsychiatric phenotypes, which is very important and can give a lot of good information about which medications might be most useful, maybe in some cases where you're likely to have more side effects because metabolism is slower. Certainly, what I've talked about today is a bit different in that we're really looking at pharmacogenetics related to the genomic abnormality or genetic abnormality that we saw, at least in the case of strength theory overexpression. And that is something that I think is kind of an area that's been understudied. I think there's just been, it turns out, it seems that identifying these genes that cause neuropsychiatric disorders specifically, it's just been a lot more challenging than for some other disorders. So that particular testing just is not available yet for most neuropsychiatric illness.
Another question that somebody from the audience had is about the peripheral expression of proteins like Shank3. I know that David Ginty's lab and Lauren Orefice have done work looking at peripheral expression of autism-associated genes affecting, behavioral phenotypes. Is Shank3 expressed in the periphery, and could that affect things like pain tolerance?
Yeah, that's a great question. So Shank3 is expressed in peripheral neurons. Actually, David Ginty has looked at this. He's the one that published a paper, and it does seem to alter sensory perception. Um, so Shank3 is also expressed in some non-nervous system tissues. Not really clear what its function is in those. No phenotypes have really been specifically linked to deficiency or overexpression of Shank3 in those tissues. But it's a great question that could certainly play a significant role in some of the phenotypes that we see.
Another question is whether you've looked for mosaicism in skin fibroblasts. This audience member said that blood is less sensitive than fibroblasts for mosaicism in neurodevelopmental disorders.
Yeah, and that could very well be the case for neuropsychiatric disorders. No, we have not done that. We usually focus either on blood or saliva in terms of a source of DNA, just because of the ease and ability to collect a large number of samples. But I think that's a great point that there's definitely some evidence because of common embryonic origin that skin fibroblasts may be somewhat better
Mm-hmm.
than blood or saliva.
And one final question from the audience. Are Shank3 variants complete loss of function or partial? And if they're partial, can phenotypes be attributed to a competitive mechanism?
So that's a great question. In general, for Phelan-McDermid syndrome, those are loss of function mutations. The vast majority of kids with Phelan-McDermid syndrome have a deletion that encompasses Shank3 and often other genes in the region. There are loss of function mutations, specifically in Shank3, and those kids pretty much are very similar to kids with deletions. They may be slightly milder. However, that's a really great question because there are a few missense variants. We've actually identified a family with inherited missense variant in Shank3 who has definitely a milder phenotype. And again, actually, predominantly neuropsychiatric phenotypes in contrast to the severe intellectual disability of complete loss of function.
Fascinating. Well, thank you so much, Dr. Holder. We're going to take a 5-minute break and then we'll be back with the rest of our morning session.